there are some conditions where if you overstimulate, you can actually create more problems.
In re-education, would you use a longer ramp time versus strength?
It depends on how much you have. It depends on how much you have. In some cases, you know, the ramp time, and Joe, I'm going to ask you to jump in here, but the ramp time for me is more about, clinically, I use it more as a comfort measure. And then also as and you'll experience this on your own bodies, what a fast ramp time feels like and what a graduated one feels like. The other thing that I look at is how long do I want that muscle to be able to work. So if I'm worried about over fatiguing the muscle so that when they leave my treatment area, they don't have anything left to stand and walk on or to reach with, you know, I'm going to be more conservative with that ramp time so that I can allow it, or rather the rest period, the interval rest period. So there's, you know, 10 seconds on, 10 seconds off, 10 seconds on, 50 seconds off. So you allow for some recovery time. But for me, it's more of a comfort issue for the patient. Electrode placement. This is the big. This is where you get to be artsy in physical therapy, I think. Electrode placement is really clinically driven. There are some guidelines, but it's really about looking at the treatment area and getting a general idea. I move electrodes all the time. I'll put electrodes on someone and say, I'm not noticing a darn thing, so I'll try something else. It's a little bit like, it's definitely the artsy crafty part of electrical Estim for me. But you have some guidelines. You've learned about motor points, there's acupuncture points, so you have some guidelines of where to start, but you can definitely be very, very evidence-based that your patient might point. Yep.
And just briefly here, fortunately, some of the technology will help you deal with the subjective nature of each individual patient, even with electrode placement. So as we'll find out, you know, like take the, you know, an inferential as an example, when you're setting up these electrodes, a lot of times you'll set it up, patient says, well, that doesn't feel right, something's not right. You know, well, hopefully you know, that you surrounded the right area, but you're not, you know, so a lot of the machines will have a balance feature where you can control the output and, you know, so yes, electrode placement is key. You need to understand why you're surrounding a given area. At the same time, the machine will help you help the patients adapt.
Good. And then is the treatment tolerated? You know how much I like that word. So what does that mean? Is the treatment tolerated, meaning, you know, is it something that doesn't feel noxious to them? Are they having, what does their skin look like with the electrodes? Some people do react to electrodes. Is it something that resulted in the outcome that you're looking for? So if you're trying to decrease their pain or recruit their muscle, were you able to do that? You know, how do they feel afterwards? Those are types of things that occur both in the moment and then when they come back. And I think that's the part that's missing in the paradigm, is that is the treatment tolerant can often be a question that you answer a week later when they come back. So hopefully that was helpful. The main thing for this one is that from the time where it says can electrical stimulation be used with this patient, everything from that point up is the PT doing that, but it really is within your scope of practice to select electrical stimulation appropriately.
And you can ask. I see everybody just get frightened all of a sudden. Oh, I'm going to have to do it all myself. You can ask.
Yes.
And if you are working with a PT as a brand new PTA, they're generally not going to just, here's the paper, go do Estim on them. They'll help you through the process.
Yes.
Okay.
That's true.
Thanks.
Okay.
You're welcome.
Yeah. Yeah, that's very true.
You're not on your own. As soon as you graduate from the program, you're not on your own.
Yeah,
You'll still be coached.
Right, and similarly, you know, I'll have questions from assistants like, you know, I'd like to try this TENS unit or something. Try the TENS unit. Well, the TENS unit didn't work. Like, okay, well, do we want to look at an interferential unit? Do we want to look at maybe using electrical stimulation in a interferential pattern? It's like, oh, okay, yeah, let's. How do I do that? And so we go back and set it up and do it, and then see one, do one, teach one, right? This happens like that in the clinics. Any questions from me from a PT perspective about Estim? Yeah.
Now, can we prescribe a TENS unit?
can you prescribe a TENS unit? You can, and this would be a situation where you could. So, well, let me just go into semantics. Prescriptions for durable medical equipment come from physicians. We can make a recommendation, and we can get a TENS unit for a patient. You can. And you can have them sign a paper, give them instructions, and you can dispense it to them. You can dispense the unit. It's not prescribing, because that's what the doctor does, and that has to do with reimbursement as well. Insurance companies will likely not pay for any device you dispense if the physician doesn't say that they need it. So the physician writes the letter of need, which is the prescription, and then we dispense the equipment. I dispense TENS units, and assistants in our clinic dispense TENS units, and I think Beth has too, without that physician prescription, because most vendors, we have third-party vendors that deal with the billing, allow for a trial period. So we dispense, we say, take this home, use it for a month, no cost to you. Really determine if it fits into your life, it's gonna help you with your pain, if it's gonna make a difference, then we can see what insurance is gonna do with it. And you can decide, if you're using a lot less pain medication because you've got this TENS unit, there may be a big financial incentive to go get the TENS unit through the insurance company because you're gonna drop half of your narcotics. So there's a financial decision in most healthcare decisions nowadays. But we can dispense it and they can use it on their own without a physician's prescription for free for that 30 days, and that's in your scope of practice. And when you would do that is if you had a goal for that. So what would a goal be? Not that you're writing them, but what would a goal be that you would see in a chart that would make it put on the green light for you to do something like that?
Increase range of motion.
Well, for a TENS unit, not necessarily. What is the impairment, the functional limitation or disability that would cause you to give them something to take home and keep?
Pain.
Pain, right? And what are they doing about their pain? Managing their pain. So you would have a goal that would be independent with self-care and pain management. Okay? You saw that goal, and your goal is to make that patient independent. I'm going to be out for Ian. Independent for pain management. And one of those, hello Lincoln! Okay. So, then, see, if we keep this in perpetuity, no one next year is going to even know what we're talking about. We had a classmate who's a new dad. We can't be here today. His son's name is Lincoln, so that's why we're doing this today. So if you had this goal here to dispense that unit, then you can do that. And when you would write your assessment, you would write about whether or not they were independent with it when you dispensed it. Right? Patient demonstrated independence in the clinic with use of home TENS. Right? Unit dispensed. And then what's the plan? Follow up with patients next visit to see if they're able to use the TENS unit independently at home. If they can, you write that down. And when your physical therapist wants to know about their discharge plan, you can say, we did that, we're good. Yep.
So what happens in the trial period time, if they take it home,
yep,
and you have educated them as well as you can, and something happens to them?
You're fine, as long as it's documented. As long as it's documented. You can show that you gave them a handout, and you showed them how to do it. There's in-clinic demonstration. There was no adverse reaction. And they have a manual that goes home with them. And in part of your instructions, you tell them, make sure you review the manual for home use. And you write that down. And then if they decide to do something creative, we had some conversations in Joe made a little smart because patients get very innovative with their home electrical stimulation devices.
Check out YouTube, you'll see some.
So, they get very innovative. So as long as you document that you did your part, once they leave you, they're a human being. You cannot control what they do. You can only control what you provide. Okay. All right.
Who's ready to try some of these?
Yeah.
Yes. All right, so on the front of your packets, there should be a number 1, 2, or 3. All the ones are going to be with Joe.